So this is week 2 of the 4-week series. Last week, we talked about prevention and how to minimize our need for using the medical system. This week, and also a major aspects of the medical system. This week, we will talk about how to make the most out of your appointments, how to communicate with your doctor, and how your doctor thinks typically. So, some disclaimers, same as last time. This is a generalized view of a complex system. So it will be a bird's eye view of a very big system. There will be some potentially upsetting information just because some things about the medical system are not pleasant necessarily. And also, it's not individualized medical advice. If you need individualized medical advice, I would suggest seeing your medical provider. But I will touch on a lot of useful things that will be useful for you personally, hopefully. And also, the last disclaimer is that this is one doctor's point of view. So I will have references, and if you have questions about those, I'm happy to answer those, but keep in mind, I'm only one person. We will have time for questions at the end, if there are any. So let's get started. Start with clinic appointments. So these are the most common types of appointments people will have. Usually people over 65 will have about 80% of their medical interactions be in a clinic setting, outpatient clinic. So the bulk of people's time in the medical system will be in a clinic. Now, there are a few things that I think will be helpful to know up front. One of them is just the logistics. So for example, it's useful to know the time allotted for your appointment. You can ask about this ahead of time. You can ask the scheduler how long you're going to have. This is useful in order to know how you budget your time, basically, as far as what you bring up. And also to help you kind of minimize distractions in terms of, okay, I'm going to be here from 10 to 10:30. And if you know you're going to have phone calls and that sort of thing, be prepared for that, because if you have a phone call in the middle of the appointment, if you have to take it, you have to take it, but it will take time away from that interaction where you want to communicate something to your doctor. So that's important to keep in mind. The other thing is knowing the purpose of your appointment. And usually people do this up front when they schedule, and they already have a specific problem in mind, or it's after a surgery, after a hospital stay. It could be for chronic conditions. Knowing ahead of time what the doctor's gonna ask you and what you're gonna ask them will be useful in order to make the most out of that appointment. It could also be just a routine checkup, like a physical, in for labs, that sort of thing. This is also a good time to bring your questions. If you've had questions maybe during the year you weren't seeing the doctor, and writing them down is useful, and kind of just bringing those in. Having a list of the top 1 to 3 topics you'd like to cover can be very useful, because then you'll get to those most important topics to you. And of course, it's primarily important for you to address the things you want to address. Most of the time, the doctor will want to address something him or herself as well. But having that list of topics and limiting it to no more than 3, I would say, makes it more likely that they will be all addressed. I should say that there was a study done several years ago looking at how quickly doctors interrupt patients. So as soon as you walk in, hi, how are you, so on, and you start talking about your concern, on average, doctors take about 11 seconds to interrupt. It used to be 8 seconds, so it's a little better. Yeah, so the point of that is you want to know what you're going to say and get to it. No one likes to be rushed, and hopefully you shouldn't feel rushed. But the reality is a lot of providers will interrupt you. So being ready for that will be useful. And then the other note is taking notes. So have a pen and paper ready. That's very useful so you remember. Oftentimes people, only retain 10 to 20% of what they heard in a doctor's visit. So having things written down can be useful. I'll talk about how to use online portals and how to minimize what you miss by using online portals and being able to see doctor's notes and that sort of thing. But nevertheless, taking notes is useful, or bringing at least a second pair of ears. That's also useful to have like a third party there who can help you out, not only to listen, but to have input, especially if they know you well. You might have a lot of things on your mind, and this other person can help you kind of, oh yeah, remember you wanted to talk about X, Y, and Z. So that can be helpful. And then kind of near the end of the appointment, a lot of doctors will kind of have quote unquote homework for folks, whether that's, checking your blood pressures, changing a medication, keeping it, monitoring your blood sugars, what have you. So knowing what your task, so to speak, is important, because that doctor usually relies on you doing that so that at the next appointment they know what to do. Med changes might be another thing, labs to come in for, referrals to call. So oftentimes after leaving a doctor's appointment, there will be, a list of at least 2 to 3 things to follow up on your own. And then at the end of the appointment, checking out is important, meaning going to the front desk and making sure you have a follow-up for the next visit. That can be useful because if you wait too long to schedule a follow-up, then usually, things get booked and you have to wait even longer after that. So doing it right after you're done can be useful, even if you don't know your schedule exactly. One side note is that near the end of your appointment, I try to encourage people to avoid the, oh, by the way, I'm having chest pain situation, where you wait until the end to get to your main concern. That is not helpful to anyone. It's not helpful to you because it'll probably shorten how much the doctor can get to your concern. And also, the doctor probably won't like it because it will delay his or her going on to the next patient. But because if it's something like chest pain, obviously that can't be ignored and has to be addressed then. So if you're having chest pain or some other major concern, bring it up front at the beginning, and then that can be addressed more thoroughly rather than in a rushed fashion at the end. That doesn't happen very often, but when it does, it puts everyone under stress. All right. So medical records. Medical records is one of those kind of hidden things that lots of patients don't see, most of it, medical records, but they're extremely important. Your doctor should be reviewing your medical records before you come into your visit, especially if you know them already. They may not have records, though, if you're completely new to that doctor. But having complete records can save you time. It can save you money in terms of not having to repeat testing, not having to go back and see where you had X, Y, and Z done. The redundant testing can make a real difference, because if a test is done multiple times, that can actually bring harm. Let's say you had a CAT scan done 6 months ago, but there's no record of it anywhere, and then you have to repeat it. Well, a CT scan is not benign. It has radiation associated with it. So that can actually, depending on the situation, can be quite detrimental if the records are not there. Unfortunately, our medical system is not all interconnected, so not all medical systems will be communicating with all other medical systems. There are workarounds around that, but if your electronic medical record system for your current system is completely different from your previous one, then they might not have access to that, the doctors, except through paper records or faxed records, as antiquated as that is at this point. If you're going to your doctor, especially the new doctor, don't necessarily expect that they have your records unless they've confirmed that with you, or you've already dropped them off at their office, for example, and so you already know they have it. For example, if you go to an outside organization and you have a specialist see you and you want your primary care doctor to have those records, they may not immediately get those records automatically. So I often recommend people to ask their specialist to explicitly send records to their primary care provider. If and sometimes that doesn't even happen, things fall through the cracks. So it's always a good idea to have your own records. How do you do that? Well, you can request them, but it's easier if you have access to the portal, online portal that system has, and then you can either print them yourself or forward them yourself to your provider. Oftentimes it's easier if you just ask the provider you want to receive the records to ask them to request a fax from the other provider. That's usually the most efficient way to get the records in my experience. As far as pitfalls when it comes to medical records, so there are some delays. That's not unexpected in transferring records. Old records could be destroyed. I believe legally organizations are obligated to keep records up to 7 years. Most organizations keep up to 10 years, but beyond that, they could destroy the records and you would never see them again. So again, why it's useful to have your own set of records and keep them yourself in case you ever move somewhere else and you don't have access to that MRI result again. If you have your own printed or saved records, then you can, take that on your own and you don't have to rely on whatever other organization has those records. There's also the hindrance of consent requirements. So some organizations are very strict about asking patients for their signed consent to transfer records. So they may have you sign a form that says, yeah, I allow such and such provider to get my records, and they won't transfer records unless that is signed. That varies by organization, but again, another reason why to have your own set of records. So as far as communicating with doctors, this is important for many reasons. So if communication is the key to many diagnostic inquiries, so how we as doctors figure out what's going on, the bulk of it is by asking you questions, just telling us how you feel, when it started, what makes it better, what makes it worse, where it is, etc. All these are clues that if we ask the right questions and the problem is something that is discoverable, then a lot of the time we can either have a really good idea or already know what's going on even before examination. So on the doctor side, the doctor's responsibility is to ask the right questions. On the patient side, the responsibility is to give truthful answers. So that doesn't mean you're intentionally lying. Most people don't do that. But that does mean, in a way, keeping a certain mental record of what has been going on. So let's say you have a stomach ache, today, and it goes on, and you don't plan to visit the doctor, but you may in a couple of weeks. It's good to just keep in mind, okay, when did this start? What was I doing when I had the stomach ache? what made it worse, what made it better, just keeping kind of mental notes so that when you do see the doctor, if you eventually see one, you can provide accurate answers to what has been happening. So kind of having that mindfulness of what's been going on can help you a lot in terms of giving the answers that can help the doctor figure out what's going on. It's also important so that we as doctors can figure out what the next steps are. And we rely on those answers heavily. So if someone tells me they've been having a stomach pain for 2 days, my thinking is different than if they tell me they've been having the stomach ache for 2 years, right? Those two are potentially very different problems. And having a good idea of the timeline makes a huge difference in terms of what tests I'm going to order, what other questions I'm going to answer or I'm going to ask, and so forth. So yeah, kind of gathering that data, if it's a blood pressure problem, gathering blood pressure measurements and having that ahead of time so that you can make the most out of that appointment when you see the doctor. And then asking follow-up questions. So this helps you, obviously, to understand if there's something that doesn't quite make sense. You should always, ideally, feel comfortable about what the doctor plans to do. If something doesn't make sense to you or just doesn't click, asking questions is perfectly reasonable. And if you don't feel comfortable with something, then chances are you might not follow through with it. And if the doctor doesn't know that, then really that doesn't help anyone because you don't get the help you need and the doctor is in the dark as far as what you're going to ultimately do. So asking questions is very reasonable. The doctor should be able to give you a good reason why he or she is doing something, whether it's a test, procedure, what have you. And if he or she can't give you a good reason, then maybe we should question why that's being done. And then the other reason is to help the doctor understand you. So if it doesn't seem like the doctor quite understood what you were saying, then asking clarifying questions of the doctor can be useful in order for the doctor to, for you to make sure that the doctor understands it. Now, of course, that's also the doctor's job to make sure he or she understands you and knows where you're coming from. But, communication can have pitfalls. So keeping that in mind is important. In terms of whether an interaction is in person or by phone or even by computer portal online, nowadays there's a lot of interaction that takes place remotely that doesn't necessitate or doesn't happen in person. And but the reality is many conditions cannot be assessed remotely. Sometimes you do have to be in person, whether it's because someone has to take your vitals or examine you and actually see what's going on in person, press on your belly to see where the pain is, what happens, looking at a rash, stuff like that. Sometimes it has to be done in person. When things are appropriate to kind of discuss by phone or through video or through online portal by text on the portal, typically you want to keep that focused on a particular problem. Since it's not an in-person visit, it's a lot harder to, address several problems all at once. So you want to keep it to one or maybe two problems at most when you're doing it through phone or through online. One of the main reasons is because A, those interactions usually are shorter, and B, it's a lot more likely for your problem to be addressed if you limit it to a few one or two problems. Because if you send a text or a message that involves like 5 problems, well, human beings are human beings. A lot of doctors won't address all of them at once, and you may actually not get any of them addressed because they're so overwhelming. They might just say, oh, this is a lot, maybe just come into the office and then leave it at that. So if you just keep it to one or two problems, you have more chances of that being addressed. Long messages are also not very fruitful. We all wish that we had the time to address, a page of worth of messages, but the reality is that just doesn't really happen all that often. So if you keep it to a few sentences, concise, with relevant information, then you have more of a chance of that being addressed properly. Of course, online portal messages should never be used for emergencies. If you're having chest pain, shortness of breath, you're losing a lot of blood, obviously call 911 or come into the ER. Don't use the online portal. Online portals are for things that can wait a business day or more, because that's usually the shortest amount of time most doctors will answer those messages. And sometimes it takes even longer than that. So don't use that for emergencies. It's always reasonable to pick up the phone and call and actually talk to a person, usually the nurse. If you have questions about, okay, do I need to come in? Can this wait? Do I need a separate appointment? Just talk to a nurse, and that can help answer those questions more easily if there's a doubt. As far as using the portal, so taking advantage of what information is in the portal is super useful. The portal we use here is MyChart, and it's in the Epic system. So you can look at your med list. You can look at results from labs, x-rays, other imaging. You can look at your doctor's notes. So the actual notes that is in medical lingo, but that's the actual note that goes in the chart. You can look at after visit summaries if your doctor kind of wrote out notes for you to see, to follow up on things. So lots of useful things. Not everything that the doctor can see in the chart is viewable on the portal. Most of the time, things like scanned documents usually are not viewable on the portal, but a good bulk of the information can be seen. So if you, had a packed appointment with a lot of things discussed and you don't remember maybe a few details, it's quite useful to go back and look at the notes that were done, and hopefully those questions that you have about the details about recommendations and so forth will be in the doctor's notes, and then you can kind of address that or answer that question for yourself just by looking at that. Now, another point is style differences between different doctors. So, we're all different human beings, so we have different styles of communication. We have different preferences as far as how we address different problems. Some doctors prefer to get back to you by phone. Some doctors prefer to do it by the portal, some even by letter, depending on the urgency of things. They may use any of those three. Some doctors prefer to see you more frequently in person. Some doctors are okay with dealing with things on the portal more often than in person. So knowing these things ahead of time and kind of knowing the style that your doctor uses is important in order to kind of have a fluid kind of relationship in terms of, okay, this is the style he or she prefers, and also this is the style you prefer. So if you don't use a portal and you just don't like computers and don't want to use a portal, that's important for the doctor to know, because if he or she sends you a bunch of messages to the portal but you don't check your messages, then that's not going to help you. So letting your doctor know that you're not going to do that is useful, so that he or she can either call you or send you a letter, whatever your preference may be. The whole point of this is to help you, improve your health. So, working together to achieve that is kind of the goal. Usually these things are established on the first visit when you first meet your doctor, as far as you know, how he or she operates. There are other points of style that are different. You know, there is no such thing as the perfect doctor. No doctor will be able to, you know, fulfill everything that you would want necessarily. But in my opinion, your doctor should be able to at least be open to your major values. So if you value your autonomy, well, ideally your doctor should value your autonomy too. And if that's not valued, then maybe you should look at seeing someone else. Because if that's so important to you in terms of your medical care, then you know that should be a priority. When you first see a new doctor, it is really a sort of mutual interview. So especially if this is going to be a long-term kind of relationship, you know, you ask questions. You're there for medical issues, obviously, and you kind of see how that's dealt, but you can ask questions about, okay, you know, what's your style? How do you deal with this? Are you knowledgeable in a certain problem that you have? And if not, you know, how would you address it? So this especially becomes relevant if you have a more complex medical condition and you're not sure if this doctor may be able to address it. And that's fine. Not all doctors can address everything, of course, but at least if that doctor knows what to do, whether it's referring you to the right person or asking others about the condition, knowing that ahead of time when you're first meeting a new doctor is quite important. And then going back to the paternalism differences, meaning some doctors are more directive as far as telling you this is what you will do. And I would say, especially in Wyoming, a lot of people don't like that. They prefer to, you know, take ownership and kind of do what they want and, you know, have information in order to direct them. But not many people I know like to just be told what to do. So knowing how your doctor handles that is important, and whether he or she respects that is really important. So I wanted to mention kind of a few points about how doctors think when they first see you and you walk in with a specific concern. What's going through their minds? How do they process what they're looking at? Why are they asking certain questions? So this kind of setup here, the bullet points, are a basic kind of flow of how we learn in medical school how to address problems. So we start with the main concern. So that may be you have abdominal pain, you have chest pain, you have anxiety, you have broken finger potentially. All these things, that's kind of your main concern. Those are like a 2-word quick blurb. Based on that, the rest of these bullet points, that's what directs the rest of the bullet points. So obviously, I'm not going to treat chest pain the same as I treat a hangnail, right? These are very two different problems. I'm going to ask different questions. So what you first kind of, how you first decide to frame your problem is going to affect the rest of the interview. Now, of course, there's course corrections and things change and that sort of thing, but that's kind of the first point that comes to mind. The history is kind of basically the doctor asking you questions. Like I said kind of before, when did it start? What makes it better? What makes it worse? What have you taken? Has it happened in the past? Etc. These questions are most of the time, ideally, very intentional. A question is asked with the intention to get an answer to go on to the next question. So if I ask, where is the abdominal pain? I'm asking because if it's in the upper center of the abdomen, it's a totally different set of possibilities than if it's in the left lower part of the abdomen. So that first question kind of directs me to ask the next question. And all these questions are intended to kind of hone in on the actual diagnosis. Now, as I said before, the bulk of what a doctor will do in terms of finding out a diagnosis is in the questions. All those questions are intended for that. And more often than not, the diagnosis will be revealed with those questions alone, without having to examine. Of course, the examination oftentimes is needed to corroborate or deny whatever the doctor is thinking, but those questions form the bulk of that. The physical exam. Now, these things I should point out usually happen in this order, and it happens in that order for a reason, because you first want to ask enough questions to know what to look for when you're doing a physical exam. It's not possible every time to do a complete physical exam of every body system, in the body every time. That would take too long. So when questions are asked, they're asked with the intention of specifically looking at what am I going to look for, what am I going to listen for when I do my physical exam. Do I need to listen to your heart? Do I need to just look at your foot? If I look at your foot, do I need to move it a certain way? Do I need to press on it? Do I need to have you walk on it? All these things usually are figured out in the history part of the interview, basically. And then once I get to my exam, I know what to look for. I know the exam is basically designed to rule in or rule out problems. So, if you complain of leg pain and I'm looking at your leg and I don't see redness, well, that rules out certain things, but possibly rules out infection, possibly rules out, a rash, something like that. But I'm doing my exam to basically, again, hone in on the diagnosis. Testing is in the same way. So whether it's lab testing, blood work, imaging, even testing during the exam, like special maneuvers that might be done, these are all designed to hone in on the diagnosis. And then finally, you get to the assessment. So that's kind of the doctor's summary of what's going on. Okay, this is what I see. These are the clues that make me think this is what's happening. Plan is what it is. Just, okay, I'm going to either give this medication or do this procedure in order to solve this, or do more testing. Of course, throughout all this, as you can imagine, there's course corrections. So if I thought it was something at the beginning, and then as we move along, you say something that, oh, that's a little off from what I thought it was, and then I look at your exam and it's a little off, well, I have to course correct. I might have to go back to the history and ask you more questions, because what I thought it wasn't, and now I'm kind of correcting for that. That happens all the time. That's pretty typical. Now, on this last bullet point, as far as the influence of medical training on the approach we take. So medical training, there's 4 years of medical school, which is just basic, a lot of basic science, basic biology, biochemistry, pharmacology, that sort of thing. And then you move on to actually seeing people and seeing how diseases manifest. During the next phase of medical training, which is residency, that's where doctors actually take care of patients as doctors, because they're already graduated from medical school, but they're still in training under a senior doctor who is directing them to sharpen their skills. During residency, that's the most stressful part of training by far, because you're working easily 80 hours a week. You don't have much sleep. You're in and out of hospitals, different clinics, different specialists, different settings altogether. But during this time is the bulk of the time where doctors learn how to be doctors, in terms of how they're going to think, how they're going to make decisions, how they're going to deal with the consequences of the decisions, whether it's good or bad. Of course, it's done under guidance so that it's a safe kind of training. But during this time, doctors are trained to think quickly. So they're trained to, after seeing a lot of kind of similar scenarios, it becomes almost instinctual that a cluster of certain symptoms, a cluster of certain findings on an exam or lab findings correlate with a certain diagnosis. And the more they see that, the more they can kind of quickly think and see something, in a few seconds and know what it is without having to kind of think through every single step. Now, there's pros and cons to that. The pros is that they can see common things and immediately know what's going on. The downside is that not everything is common. Sometimes rare things happen and you have to kind of step back and be like, oh, this doesn't fit. Maybe we should take a step back and not rush to conclusions, based on the initial impressions. But a big important thing in terms of when we are patients, why does this matter when we are patients? Well, a doctor typically thinks in succinct summaries. So he or she wants to extract the most relevant information out of the interaction, whether that's your answers to questions or exam findings, and come up with a summary that makes sense. So when you're interacting with a doctor, it's useful to keep as much of the relevant information up front and as much as the irrelevant information in the background. Now, of course, it's not always possible for you to know what's relevant and what's not relevant, which is where the doctor has to ask the right questions and kind of bring that to the forefront. But keep in mind that if you notice a doctor kind of getting impatient, it might be because they want to get to the quote unquote relevant information that helps you the most in terms of figuring out that diagnosis. Just know that that may be why they kind of are trying to, what seems like rushing things, they may be trying to get to a more relevant answer to get to the answer that, helps you in the end. But knowing kind of that medical training part and how they were trained to think can be useful in order for you to know where they're coming from in that interaction. So to continue, this is kind of how, in addition to what I already talked about, how doctors walk through a visit. And I'm mostly talking about like an outpatient visit, but this can apply to other settings, the ER and hospitals and that sort of thing. Typically, if I'm going to see a patient tomorrow, let's say, I look through that patient's chart beforehand, the day before, and I have a pretty good idea of what I'm going to discuss. So if that patient is going to be in for high blood pressure or diabetes or what have you, then I should have a pretty good idea of what I'm going to either recommend upfront if I know the patient well, or at least know what questions I'm going to ask. So, when you schedule your appointment and you tell the scheduler, I'm here for X, Y, and Z, I'm looking at that the day before. So if that description is not accurate, then my whole thinking but the day before is for naught, because if it's for something completely different, then whatever preparation I may have made may not apply. And that's okay if that happens, but it is to your advantage to know when you schedule the appointment what you're going to be there for, because then the doctor can prepare and make the most out of that appointment on his or her end. During the appointment, one of the things we look at, not just going through that list of, your main concern and the history and all that, but throughout that, a lot of the questions that may be asked are searching for red flags. So let's say you came in for leg pain again. Leg pain can be a lot of different things. Some are pretty benign and some can be dangerous. So for example, a red flag for leg pain might be if it's one leg is swollen and the other one is not, and this is completely new to you. Well, one possibility would be a blood clot. And that could be dangerous because if a clot goes to your lungs, that could be actually deadly. So one of the jobs of the doctor is to look for those red flags and ask you the questions that kind of rule out those first. If you come into the appointment thinking, well, this is just, a sprain, and it may just be a sprain, but part of the job of the doctor is to make sure whatever is you're coming in for is not going to kill you, right? So that's where they search for red flags. So if you get a lot of questions and you're like, why is he asking all those questions when I'm just here for a sprain? Well, maybe it's because they want to rule out some other things that are, important to not miss. This is the next bullet point about finding patterns. That's kind of what I was talking about as far as, a certain set of symptoms may most of the time indicate a certain diagnosis. And this is how we kind of think and arrive to a conclusion more quickly because we have these patterns already set. And we all do this in our daily lives. We have certain patterns of behaviors, or, if we see it's a cloudy sky and it's gray and it's starting to get windy, well, we know that there might be a storm coming, right? You don't have to like list out every single event and then come to the conclusion that a storm is coming. You kind of just look, see it. Oh yeah, a storm is probably coming. Same kind of thing. You see someone who's having, let's say, chest pain that goes down their left arm, and they're sweating and their pulse is high. Well, you probably are aware that that might be an indication of a heart attack. So there's, probably hundreds of these clusters of symptoms that we have to know right away in order to arrive at a conclusion. But like I was saying earlier, knowing when something doesn't fit is important, because not everything that what the saying goes, not everything that gallops is a horse. So sometimes it's a zebra, right? So most of the time, it'll be a horse because horses are more common, and that's what they appear to be from a distance. But on occasion, if it's something rare, it might actually be a zebra, and you have to look into it and not treat it like a horse, right? The other point that I like to make a big point of is testing with a purpose. So if I'm going to order a test, whether it's a blood test or an X-ray or what have you, I should be having a question in mind to answer with that test. I shouldn't be ordering the test just for kicks. If I'm going to order a test, then I should know what to do with whether the test goes one way or another. And this is important because I could order hundreds of tests. I have that ability to just pick from hundreds of tests. But of course, I don't want to waste your time. I don't want to waste your money. I don't want to put you through a bunch of unnecessary testing that's not going to give me anything useful. So I have to be responsible with what I ask you to do. And this is part of going back to asking questions. If a doctor is ordering a test, he or she should be able to tell you why he's ordering the test and what he expects to get from it. This becomes relevant if you don't plan to do anything with the results. So let's say, for example, you have a minor heart condition, and you're discussing with your doctor about maybe doing an ultrasound of your heart. But you might not plan to do anything with that condition, whether it's because of personal preference or some other reason. But if in the end you don't plan to do anything with that result, then we have to question ourselves, why even get the test, right? And if your doctor can't answer that, then, well, maybe it's time for more questions in terms of whether to get that test or not. Another point to make is, what does a normal test mean? Well, unfortunately, there are always variations of normal. So a lot of, for example, blood tests are defined normal by what, let's say, 90% of the population has. So let's say a thyroid test is a good example. How do we know what a normal thyroid number is? Well, usually they take a group of presumably healthy individuals that are not having symptoms, and they draw their blood and they plot like where in that distribution of numbers they fall. And if 90% of those fall in a certain range, that's considered normal. That's just one example. But of course, there's variations within that. You may be in the, upper 5 percentile of that and still not have a major problem. So whenever we do a test and a result comes back, it's very important to know what the context is. If you got a test because you're having symptoms, certain symptoms that might be illuminated by the results of the test, well, it makes sense to do the test and to kind of interpret that test in that context. So let's say you're having symptoms of having too much thyroid hormone. Well, if I get the test and it shows, okay, you have a high thyroid hormone, then I can correlate those two, your symptoms and the test result, and that makes sense. If you're not having any symptoms and your test shows that you're having a high thyroid hormone, well, I have to step back and see, okay, is this test, first of all, reliable in terms of the conditions it was drawn under? Does this result make sense in terms of, well, if this is an extreme result, would I expect you to have extreme symptoms? And if you don't, well, maybe we should just repeat the test and see if this is an actual real result. So having that context is important. There's also the variation that is very slight. So a lot of times we get, let's say, electrolyte tests for your blood. And there might be a number that is just off what's considered normal. Sometimes this is not clinically relevant, meaning that it's not going to affect your health if it's just slightly, a 1/10 of a decimal off of the normal. But this also depends on context. So did you start a new medication? Did you, were you dehydrated at the time when you got the blood drawn? So these are all context clues that the doctor will take into account. So if you get a test back and your doctor says these labs look normal or essentially normal, and you see that one is a little bit off, he or she might be telling you that it's normal because of the context. It might not be significantly off the range enough to justify doing anything for it. Now, of course, doctors make mistakes too, so they might have missed something. So if you have questions, you can always ask and just verify about that. But that's another point, especially if you have access to a portal, you might be able to see the results even before the doctor sees it. So, you might have questions about it and, is something going on? I usually have patients, wait for me to kind of summarize the results so they can know that I saw them and know kind of within that context that this is how I interpret these. But again, if you have questions, it's your health. You should feel free to ask them. And then a last point here is that most things in medicine, in biology, in life really, are nuanced and are probabilistic. What does that mean? Well, not everything is 100% or 0%. A lot of things are simply somewhere in the middle. So you will hear a lot of doctors say things like likely, very unlikely, unclear. We can use other terms to describe this, but these terms are basically, they're not necessarily to try to evade questions or anything like that, but sometimes the answer simply is not 100% clear. And all we can say is, yeah, these tests likely show that you have A, B, or C, or most likely you don't have this condition. There are very few things in medicine that I can say with 100% certainty this is what it is. that's just not how the world works. And, there's gray. And, I try to be as honest as possible about that. And I try to avoid terms like always and never. All right. So going on about how doctors think, whether you are in an ER, an emergency room, or a clinic or a hospital, these are all different settings where the doctor may think differently. So if you walk into the ER and you say you have abdominal pain, the doctor there might think differently as far as what possibilities there are of what's happening with you than if you walk in with the same symptoms into a clinic. Now, why is that? Well, because there's context. Most people walking into the ER have an actual emergency that it may be life-threatening. So the framework of that doctor in the ER will be, okay, let's not miss anything that's life-threatening. Let's rule out everything that's life-threatening. And that's kind of the focus. In a clinic where usually more chronic conditions are seen, the focus may be, okay, is this going to affect you in the long term? So as an example, if you walk into the ER and they do a bunch of testing because you're having abdominal pain, and they happen to, for whatever reason, draw cholesterol labs, let's say, well, that doctor probably won't address your cholesterol, simply because in that context, it's not going to be life-threatening in the moment, that day. But if you walk in and you do those tests in a clinic, the doctor should address your cholesterol at some point, because over time, over several years, that cholesterol will lead or could lead to problems such as heart attacks, strokes, that sort of thing. But those are different contexts. So the focus of what may be addressed are different. So this is important because, setting expectations. If you have expectations of something being addressed, if you're not in the context where that is typically addressed, it might not be addressed. So where this becomes relevant is if you have a scan in the ER. Again, let's go back to the abdominal pain example. You have a scan and they don't see that you have appendicitis. They don't see that you have an aneurysm or anything like that that will be immediately threatening. So they say, okay, you're fine, you can go home. Well, in the report of the scan, it might say, oh, you had plaque in your vessels. Well, that is not relevant immediately in that moment, so that doctor may not address that. But this is why it's important to follow up with your doctor after you've been to the emergency room, especially if you have had tests, because then your primary doctor might be able to see, oh, I noticed that you had a scan and they picked up on plaque in your vessels. That's important. That will affect your risk of heart attack, 5-10 years from now. Let's address that. That won't necessarily be addressed in the ER. And it's totally appropriate that it's not addressed in the ER because that's not kind of their context. They couldn't possibly address everything in the ER like that. That's why you have more time usually with a primary care doctor or your specialist than you do in the ER. So it's important to keep these things in mind, when you have testing. Same goes with hospital, be in the hospital. There's a different context there, nursing home. A lot of the times how the doctor approaches things depends on what the goals of care are. So someone in a nursing home might have very different goals of care than someone in the ER. Maybe in a nursing home, the goals of care might be to, for that person to be as comfortable as possible. And that's kind of the main goal. They don't expect to, cure the diabetes or reduce their cholesterol or some other thing that is more long-term in that context. So obviously what the goals of care are for you are important, whether that's something you want to address long-term or only in the short term. And then one final point as far as asking the question of your doctor, what would you do in my place? That's a very tricky question. I get that on occasion. And what I tell people is, well, I can tell you what I would do, but my values may not be exactly the same as your values. You know, I may value, you know, being able to, walk down the street and whistle. I don't know. And you may value more, sitting at home and watching a good football game. That's totally fine. Neither of those are better or worse. It's just different values, and how your health might affect your decisions depends on those values, what you would like to do, what you would like to avoid. So when people ask me that, I always preface it with, these are my values, and this is, what I would do if, assuming those values, but I can't tell you what your values are. Those are your values. You kind of have to tell me what they are, and then I can direct you. Okay, you value doing such and such. Let's move toward that goal, and then we can get to some more productive place for you. So I alluded to this as far as the balancing act that happens in a doctor interaction. So all these things that you see on the screen, those are things I have to juggle with, and in a way you have to juggle with too, when I'm interacting with a patient. So I have to keep in mind, as I'm doing the diagnosis and history and examination, I have to keep in mind, okay, what are your goals? What are you trying to achieve? That's going to guide a lot of what I do too, in terms of how much testing I do. Do I want to put someone through a lot of testing that already told me that they don't want to be tested for all these things? Well, probably not. I want to respect what they tell me. But at the same time, I also have goals. Typically, the doctor's goals are to address major conditions. So in the primary care setting, that might be address high blood pressure, address diabetes, address arthritis, or what have you. Those are major goals because I know that might affect your life later on. I know that if we don't control your blood pressure, you have more of a risk of a stroke. And obviously, I don't want to ignore that. At the same time, that might conflict with your interests or goals that day. Maybe you're more interested in addressing your elbow pain rather than your long-term risk of stroke that day. And that's fine. But those goals sometimes have to be kind of a dance. And okay, what do you want to do? What do I want to do to help you in the end? And then time, obviously, is important. When a doctor is in with you, he or she doesn't have infinite time. There's usually a slotted amount of time for that interaction. So in order to respect, the patients afterwards, he or she has to, make sure that the time is used appropriately within that visit. Documentation is kind of interesting. This varies a lot from doctor to doctor. I'll speak to my experience, but I usually type as people see me. The computer's open. When I'm typing, I'm not just verbatim typing what you're saying. I'm summarizing, going back to the history part, summarizing a question I had and summarizing the answer. So the purpose of notes for most of the time is one, to keep a accurate record of what's going on, but two, communicate to my future self, what did I do that day, so that when I see you in 2 months, I can know this is what I did. How is that affecting what is happening now? So it's kind of a FYI to myself in the future. That's a lot of what documentation is. And then there's also the insurance side, because for certain things, you have to document certain aspects. This is not as much of a problem as it used to be. Insurance used to require so much more documentation than it does now, thankfully. So for the most part, I really only record what's clinically relevant, and I don't have to worry about what insurance will and will not say. I just record what I know is medically important. And so that's not as much of an issue as it used to be, thankfully. As one, as I'm at the computer, I'm placing orders, looking up things on your chart. Let's say you mentioned that, oh, you took this medication 2 years ago. Well, I can look at the chart, hopefully, and see, oh yeah, you took that at that dose, so on and so forth. I have to do that at the same time as I'm asking you other questions. So there's a lot of multitasking in that process. And but it is very useful to be able to do that at the same time. Some doctors prefer not to type out their notes during the visit, and they later type it out after they're done, or even dictate it after they're done. It's just different styles. There's no right or wrong. Yeah, so you might notice that if a doctor is typing while you're seeing them, it doesn't mean they're being rude or not listening to you. In fact, in my practice, I listen better if I'm actively thinking, okay, this is something I should pay attention to because I have to type it. I can't type everything. So that's actually a helpful tool for me to pay more attention, is to type what's relevant. Anyway, that's that point. Another point is, unfortunately, we do have to some extent, kind of keep in mind what may be affordable or not. If you tell me, I'm having trouble paying for my medications, well, as much as I would like to say that shouldn't matter, I'll give you, this other medication. If you can't afford the medications, you're probably not going to take it. So that's not going to help you. So I have to maneuver, okay, let's find the next best thing that I can do for you within what you will realistically be able to do. And it's one side of things that I don't think any doctor likes to have to deal with, but it is reality. And I'll go into some workarounds, either this presentation or the next, as far as, I guess it will be next, about as far as medications and like how to help you get more affordable medications. And a bulk of my time has been spent finding those loopholes for patients. So I try my best to help people in that sense. But that is a reality sometimes we have to face. And then another thing that's going on in the doctor's minds is the next steps. So I'm kind of thinking 2 steps ahead as far as like, okay, if I decide to do this test, again, what am I going to do with the result? What does that mean for you? Does that mean you're going to have to travel, 100 miles to see a specialist? Is that something you can do? Is that something you've told me in the past that you would never do? All those things I have to take into consideration when I perhaps suggest a test as an example. And then there will be unexpected interruptions. Phone rings. There's someone comes in the door asking about someone else. There's interruptions all the time, and we just have to kind of just go along with them and go with the flow when that happens. One quick point on documentation. So for the past year, maybe 2 years, more and more practices are using artificial intelligence to document. So we don't have this here yet, but just so you know, because you'll probably see it at some point, the way a lot of practices are doing this is there might be some sort of recording device, and you should always be like told that this is happening. So ethically, if something is being recorded or transcribed or anything like that for the purposes of documentation, it is an ethical duty to tell you as a patient, okay, this is being transcribed by artificial intelligence. Are you okay with that or not? And then your consent should be given or not. If you don't want it, then they shouldn't use it. But the idea is that an artificial intelligence program would pick up on the conversation that is happening and would basically function as a scribe. So you might have been in situations where a scribe is present, like a human being who's at a computer and basically is just listening and taking notes. That's kind of the idea. But instead of a human being, it'll be a artificial intelligence piece of software. The idea here is that it extracts the relevant portions of that and puts it in a note. Now, of course, the doctor is always responsible for ultimately being able to sign off on what is written and editing if something wasn't correctly picked up. But in an ideal world, the purpose of this would be to allow the doctor to not have to all the time be in the interacting with the computer and just focus on interacting with the patient, right? So, and again, ideally, I don't know if this will work out ideally, but ideally, that would mean I could ask all my questions. I don't have to worry about typing. I could move more smoothly through those questions. I could, do the exam and, go through perhaps counseling people about, okay, this is what these tests mean, blah, blah, blah. And that would save time in the end by me not having to type all those things out. So again, that's the ideal world. I think we're still in the early phases of that. The implementation that I've seen of this happening, it's not perfect, but I do expect it to get better over time. So we'll just have to see where that takes us. Like I said, that's not available here yet, but I would expect at some point it will be. So, all right. So, reasonable expectations. This is things that you as patients, me as patients, when I go in to see my doctor, these are things that are reasonable to expect. So we should expect that our goals as patients are important. That seems kind of obvious, but you should feel like when you see your doctor, he or she respects what your goals are and your values. And your autonomy should be respected as far as you get control of your own body. You don't get to have procedures done without your consent. Informed consent, that means you know what to expect reasonably. You know what possible complications there may be. That the doctor has done this before and they're not just winging it. All those things. That's your autonomy. That is extremely important. That is reasonable to expect. At the same time, it is also reasonable to acknowledge that reality is important. What do I mean by that? Well, there are limits to biology. You can't expect your doctor to work miracles as much as we want that. There are also social limits. For example, this comes in if someone has a limitation, a physical limitation to do their job, and they have to make a living and have to put food on the table. So me as a doctor, I have to have that reality in mind as far as this person needs to make a living. Whatever I do needs to take that into account, and then the person has to also take that into account in terms of what they're going to decide for their health choices. Same goes with financial realities on that front. So another reasonable expectation is using health advice to make your own choices. So doctors should be primarily advisors, not enforcers. We're not going to force anyone to do anything. If the exception might be if you're in a car accident and you're unconscious, well, you can't provide consent at that time, right? So presumably you want to be pulled out of the burning vehicle, and I'm not going to wait and ask you until you wake up to do that, right? So there are certain obvious kind of circumstances like that. But if you're completely, capable of making your own decisions, then you should be completely capable of being asked to make your own decisions and be given advice and asked for your permission before anything is done for that. At the same time, that does mean that there is a responsibility of asking questions if you have any, like I was alluding to, asking why, asking how, asking expected benefits, risks, that sort of thing. Healthcare is a two-way street. So, your doctor can't do everything for you. Doctor can perhaps prescribe you something, give you advice, but then it's up to you to actually do the bulk of the work. You have to like monitor your blood pressure, or you have to, watch what you eat, or take the medication, or what have you. Most of the work is on that end, and it's not uncommon that sometimes I prescribe something and I think that person is taking it, and then it turns out they're not. Well, that kind of limits what I can do for them, right? Because if I know that a certain medication will help, but that person doesn't take it, well, there's only so much I can do at that point. So it's a two-way street. And then, mistakes happen. We're human. Things happen. The important thing about mistakes, it's not necessarily that we're going to completely avoid mistakes. That's just not going to happen. I've certainly made mistakes. The important thing about mistakes is, first of all, acknowledging them. Acknowledging that you made a mistake and being open about it. So, if you see a doctor and perhaps you notice they made a mistake and they are not upfront about it, to me, that's a red flag. And it's possible they didn't notice it. So it's perfectly reasonable to point it out and say, hey, do you think this is right? And, if the doctor is open and honest, maybe they'll recognize, oh yeah, that was a mistake. Let me see what I can do to correct it. And also, very importantly, learn from it so that this doesn't happen again, or has less of a chance of happening again. Mistakes happen also on the patient side. Maybe you forgot to take your medication for a week. That happens. It's okay. But not being upfront about it also hinders your care. So if the doctor thinks you took your medication, but you didn't, and then interprets labs a different way, that could be harmful, actually. So it's important to be upfront both ways, when that happens. And then finally, as far as switching doctors. So sometimes, if something doesn't work out, like I said before, if your values are not respected, or it's just not, that doctor doesn't have an experience with your condition, then it may be time to switch doctors. There are pros and cons to this. It might be good to get another opinion. On the other hand, if that doctor has known you for a long time, you may lose that kind of continuity. So it's something you have to weigh for yourself as far as if you wanted to switch that. But in my opinion, you should never feel stuck or forced into just seeing one doctor forever. It should be kind of, if your health is being addressed properly, again, realistically, then yeah, kind of analyzing that, and if there is a need to change doctors, and that sometimes happens. Along these lines, it's important to know what your deal breakers are. So, for example, I'll give my personal deal breaker. If a doctor doesn't respect my autonomy, that's a deal breaker. If I don't get the sense that he or she is gonna, respect my decision to do X, Y, and Z, assuming it's a rational, reasonable decision, then that's a red flag, and that's kind of a deal breaker for me. However, one should keep in mind that what the purpose of that particular doctor is. So let's say you're going to a surgeon to get your gallbladder out, but the surgeon may not be as nice as you might want him or her to be. Well, if the purpose of the procedure is to get your gallbladder out and the surgeon is perfectly competent to do that, maybe that niceties is not should not be your first priority. Ideally, yes, everyone should be nice and all that, but sometimes you just have to keep in mind what the purpose of you being there is, and if you're not gonna interact with this person long term, and you're gonna get the main thing done, then maybe you should kind of prioritize what you're there for, and just keep it at that. One has to be realistic about these things. Not to pick on surgeons, but sometimes that example comes up. So, all right. So, I think this is the last slide. But so some limitations I'd like to point out in terms of when you see a doctor. So there are a lot of variations between training styles that a doctor goes through. So, ideally, all doctors in a certain specialty go through the same type of training and are capable of doing generally the same things. So you would expect a general surgeon to take out an appendix and take out a gallbladder and fix a hernia, for example. And you would expect all general surgeons to be able to do that. But their individual knowledge will vary, obviously, because of experience, because of where they're trained, because of what they're interested in. So a certain surgeon might be more interested in the nuances of putting in a mesh for a complex type of hernia. Well, that's fine. Like, that surgeon kind of has more experience with that than another surgeon, perhaps. But where this becomes more relevant, perhaps, is topics that are not covered by training. So here are a few topics that typically are not covered by medical training. Insurance and billing systems. Most medical training does not include how to deal with insurance. That's something that doctors learn on the job. Because there are probably hundreds of different iterations of insurances, there's just no way for doctors to keep up with what your individual insurance might be and how it's billed and all that. So that's not something that's a focus in medical training. We have to learn because reality slaps us in the face as far as like, well, you might not be able to do this because insurance doesn't allow it. But medical training is just not focused on that. Another thing that still surprises me is how little training is given in medical school for nutrition and exercise. Personally, I think nutrition and exercise is just vital to what I do in terms of primary care. So I personally just did more training on my own to learn more about nutrition and exercise, but it's not something I learned thoroughly in medical school. And this is important because a lot of conditions can be made better or worse by nutrition and exercise. So if if we're not getting the proper training, then we're missing out on a whole section of possible ways to treat things. So that's something that doctors can obviously go out and train on their own, but it's not a default. So it's kind of important to know that. And this is where you asking questions is important. If this is something that is important to you, nutrition, exercise, it's very reasonable to ask your doctor, oh, how much experience do you have with counseling people on their diet, for example? Yeah, so then that way whether to ask that doctor further questions on that topic or not. Herbals and supplements. There's another area that is not covered thoroughly in medical school. One of the reasons is because oftentimes these supplements and that sort of thing don't have a lot of research behind them. That's not always true. There's certainly some herbals and supplements that do have a lot of research, but they're just not covered necessarily in medical school. So this is something that, again, as far as primary care doctors, oftentimes they have to learn because people come in with oh, I'm taking this herbal supplement or I'm taking this vitamin. And we kind of have to learn to know, oh, how does that affect your health? I can't just ignore that entirely. Um, so that's on me to kind of learn more about it. And I have learned a lot from people. People sometimes come in and say, oh, this helped me with my diabetes. I'm like, interesting. I had not heard of that one before. Let me look into it. So I've actually picked up some nice kind of uh, nuggets, I guess, of different like supplements and that sort of thing that actually do have data behind them, but I just didn't look into it beforehand. And again, no one can know everything, so it's kind of nice. It's really exciting to learn that sort of thing when someone comes in and teaches me basically about something that I hadn't learned, and then I look into it and I can actually take that to other people. And obviously, it's my job to research it and make sure it's not just some fringe thing that doesn't work, but it's legitimate, and that's kind of exciting to me. And then legal concerns. So we're not lawyers. We are not taught how to interpret the law. Unfortunately, there are some legal aspects to being a doctor. And, the major ones, yeah, we have to know. For example, not doing surgery on someone without their consent, if they're perfectly able to provide consent, that could be considered assault, for example. That's illegal. Yeah, I should know that. But as far as like nuances of legal things, that's not thoroughly covered in medical school. And yeah, again, no one person can know everything, and it's important for everyone really to acknowledge that we don't know everything. And when something comes up that I just don't know about, I try my best to say, hey, I don't know about this. If I can look it up and I, have the time to look it up, then I'll say, yeah, I'm going to look this up and I'll get back to you next time. But yeah, I really don't like, when people make up stuff. That's just completely unethical in my mind. If I'm going to recommend something, I want to know that at least I've done some research on it. I have some background on it. I'm not just pulling out of a hat, or at least I have some rationale as to what I'm saying, and not just pulling something out of a hat. So part of this is also, if I don't know something, I can say, okay, I don't know much about this, but I can point you to the person who knows more. And that's really important because, again, not everyone can know everything. But if you can find someone who is able to direct your care, even though that person doesn't know the answer, that can be just as valuable as that person knowing, over the long run. So, yeah, so that is the end of today's presentation. Next week, we'll talk about medications, procedures, and how to navigate the hospital.